One of the deadliest but most slept on opportunistic infections in patients with AIDS is Mycobacterium avium complex, especially when your CD4 count falls below 50. What happens is the bug will hijack the macrophages and avoid destruction by blocking phagosome-lysosome formation. So it allows it to spread through the bloodstream and wreak havoc on the reticuloendothelial system. So you'll see fever, weight loss, diarrhea, hepatosplenomegaly, and also some elevated alk phos and LDH. Also, it's going to be acid fast inside of foamy macrophages. So advanced age, less than 50 in your CD4 count, it's going to make you think of the MAC, the Mycobacterium Avium complex. So some key features: going to have that low CD4, chronic diarrhea, alk phos, and LDH that suggests reticuloendothelial involvement. Acid fast, of course, and also a negative TB, because you have to rule out TB before you know that it's going to be your MAC. All right, so we have a 45-year-old woman with untreated HIV, persistent fever, fatigue. Labs show elevated ALP and pancytopenia. CD4 count's pretty low. What's it going to be caused by? It's going to be the inhibition of the phagolysosome production. All right, that's the mechanism by which the organism evades the immune destruction. So the MAC survives within the macrophages, blocking that phagolysosome fusion, and so it can't be degraded. And some other answers would be like a polysaccharide capsule. That's going to be your Cryptococcus neoformis. That's not going to be acid fast. It is in AIDS patients, though. Toxin mediated, that's going to be your Legionella. That causes your pneumonia to spread through the water supply. Attached intestinal epithelial cells, crypto, causes watery diarrhea. So you have to see that in the question sim. And it's not going to be involving your bone marrow. And that's important. Sulfur granular formation, nocardia, which is nocardia is partially acid fast, but these are going to be in localized infections. Granuloma formation with caseous necrosis is your Mycobacterium tuberculosis, and you have to rule that out first. Okay, so there's some other facts about your MAC. So you have the carbonyl fusion stain, and that can detect your acid-fast Mycobacteria. That's how the staining works. The Mycobacteria stain acid-fast due to the mycolic acid content in that cell wall, and they invade the macrophages, and they cause the granulomas to form. And the clinical presentation is going to be a symptomatic lung disease, so it's going to be like a TB symptoms, but you have like the cough, fatigue, night sweats, shortness of breath, weight loss, and all that stuff. But you have to rule out TB for the MAC. And so yeah, just watch out for those TB symptoms less than 50 CD4 and immunocompromised individuals, and also know that this is going to have multi-drug resistance, and it's treated with macrolides. So think like your mycins, like clarithromycin, azithromycin, and ethambutol is how it's going to be treated. So also consider maybe a third agent like your rifabutin as well. And that's pretty much all we need to know about our MACs. Give a macrolide to HIV patients who have a CD4 count of less than 50. So yeah, that's pretty much all there is to know about this guy, and we'll see you in the next video.